In this video, we're going to focus on cardiac output and the regulation of how the heart functions. We're looking at the regulation. We're going to see that there are intrinsic, extrinsic factors that affect how the heart is going to function. We'll also focus on heart failure, baroreceptor reflex, and chemoreceptor reflex as well, and regulating cardiac output. So remember, cardiac output is heart rate, and both of these are going to affect cardiac output, or the amount of blood that comes out of the heart. And cardiac output and total peripheral resistance are both going to have an effect on mean arterial pressure. Primarily going to focus on total peripheral resistance, cardiac output for this lecture. Cardiac output, again, this is the volume of blood pumped by one ventricle in 1 minute. You need to memorize this formula. Cardiac output is heart rate times your stroke volume. And the units for cardiac output, you can either do them in milliliters per minute or liters per minute. So when you look at cardiac output here, we know that heart rate and stroke volume both contribute to cardiac output. And if you just multiply these two, that gives you your cardiac output. Heart rate is the number of times that the heart beats or contracts each minute. The average resting heart rate is around 70 beats per minute. Stroke volume is the volume of blood pumped per beat by each ventricle. Average resting stroke volume is anywhere from 70 to 80 milliliters per beat. Cardiac output can increase due to either an increase in stroke volume or an increase in heart rate. So the type of questions you could get on cardiac output, as far as calculations go, is I'd give you something like this. What is the cardiac output of somebody at rest? Assume a stroke volume of 70 mils per beat and a heart rate of 70 beats per minute. Now on here I have 70 to 80 milliliters, but I'll give you just one. So it'd be 70 mils, 80 mils, 60 mils, and then I'll tell you what the heart rate is, and you just multiply both of those together, and it's going to give you that cardiac output. For this particular question, I have it for both 70 and 80, so you can see how many milliliters per minute are pumped out for the cardiac output. If I use 70, and if you use 80, you have 5,600 mils per minute. If you don't want to give these in milliliters per minute, you can do liters per minute, and that's simply moving the decimal over. For example, this would be 4.9 liters per minute, 5.6 liters per minute. Either way you want to give cardiac output is fine. Well, since the average person has 5 liters of blood, actually a little bit more than that, in their body, under resting conditions, how long will it take for the entire blood supply to pass through the heart? Well, if you're pumping anywhere from 49 to 5,600 milliliters per minute, and you have 5 liters of blood, or around 5,000 milliliters, then it's going to take about a minute for every one of those blood cells to go through your heart, into your arteries, capillaries, veins, back to the heart. Doing exercise, the heart rate is increased to 190 beats per minute, with a stroke volume of around 115 mils per beat. What would be the cardiac output? Again, you would multiply those together. In this case, you get around 21,850 milliliters per minute, or about 22 liters per minute. With increased heart rate, increased stroke volume, you're going to have an increase in cardiac output. However, having a heart rate around 190 beats per minute wouldn't necessarily give you a really high cardiac output like this. Because what can happen is that the heart will begin to beat so fast that it doesn't have time to fill. And actually, when you look at what your beats per minute should be when you're exercising, strenuous exercise versus light exercise, you think that, oh, maybe if I have a faster heart rate, that's going to be better for my heart. Well, up to a point it will be, but then if it gets so fast that the heart doesn't have time to fill before it beats again, well, then that can cause a decrease in your cardiac output, and your tissues aren't going to be perfused the way that they should when you're exercising really hard. So you have to watch that heart rate so it doesn't get too high. When you look at the regulation of heart function, we have intrinsic and extrinsic factors. Both heart rate and stroke volume are going to be controlled by these two mechanisms. We're going to see intrinsic mechanisms are involved with the heart tissue itself, that the heart can actually regulate how much blood it pumps out internally. Extrinsic mechanisms are the influence of nerve innervation, hormones. First, going to focus on intrinsic. So with intrinsic regulation, the stroke volume, or the amount of blood pumped out per beat, is regulated by 3 intrinsic variables. We have our end diastolic volume, or EDV, also called the preload. We have total peripheral resistance, or afterload. And we have contractility, or the strength by which that heart contracts. So let's go over each of these terms and make sure you have a good understanding of these. End diastolic volume, or preload, this is the volume of blood in the ventricles at the end of diastole, just before the ventricles contract. So the ventricles fill, and then just before they contract, the amount of blood that's in those ventricles before it contracts is called your preload, or end diastolic volume. And the name end diastolic volume is well suited because when the heart's relaxing, it's in diastole. So what's the volume of blood at the end of diastole? Well, it's your end diastolic volume. Now, the volume of blood is the workload that's imposed on the ventricles prior to contraction. Thus, we can also call it the preload. Your stroke volume is directly proportional to your end diastolic volume, or your preload, which means that the more blood that you have in that heart, to a certain extent, the greater the heart's going to contract to send that blood out, which is going to give you a higher stroke volume. So increased preload causes an increase in ventricular stretch, resulting in an increase in contractile force, which is going to result in an increase in stroke volume. And we're going to see that this is explained by the Frank-Starling law of the heart. It's a fantastic mechanism by which the heart contracts harder with the more blood that it has in it. So in other words, if there's more blood up to a point, we're going to see that you can stretch the heart too much, but up to a point in those ventricles, the ventricles will generate more tension and eject a greater volume of blood. If there's less blood going into the heart, then you're going to have less tension and it's going to be generated. So let's take a look at the Frank-Starling law of the heart and what it says. Basically what it's showing is that the strength of ventricular contraction varies with your end diastolic volume. So now as end diastolic volume is increased, the stroke volume is increased. In other words, whatever goes into the heart gets pumped out. So as you fill more blood in the heart, more blood is going to get pumped out. So what's the physiology behind this incredible phenomenon of the Frank-Starling law of the heart? It has to do with myocardial stretch and how much the heart muscle is stretched. I remember when we were talking about skeletal muscle, how if you held out your arm and stretched it out, and you went to pick up something with your arm stretched straight out, that it's more difficult to pick it up because you have less myosin heads in contact with the thin filament, so you're not as strong. And then you bring your arm up around 90-degree angle of your elbow, and you have more of these myosin heads, all of them actually, in contact with the thin filament, and you still have room to move this across. So this is where you have your greatest strength. And then if you get closer, you bring your arm closer and closer as you're flexing your biceps until as you move those thin filaments over the thick filaments that you actually have the butting in of the thick filament against the Z disc, and they can't pull too much closer. Well, then you have a decrease in strength of contraction. So you have a decrease in strength of contraction whether you have it all stretched out or you have it contracted all the way in. Turns out that a heart that's beating at resting heart rate, those thick and thin filaments are actually around what you see here in A. There's a lot of overlap. The thick filaments are binding onto the thin filaments and contracting, but you're not generating a lot of force just because of the arrangement of the sarcomere. Now let's say that the heart fills with more blood. Well, as it fills with more blood, you're going to have stretching of that heart. Shown here, we have stretching of the heart, which means if you're stretching out the heart muscle cells, then those sarcomeres are being stretched. So here they're stretched out a little further. Now, when they bind to the thin filaments, they have more room to move them across, to have the thick filaments pull the thin filaments over themselves, and you get a stronger contraction, shown here in B. Well, what if I stretch it out a little bit more? Well, now the overlap is such that we have room here for this to move those thin filaments over the thick filaments. The myosin heads can grab on, it can pull, and you get a stronger contraction. D, you get an even stronger contraction based on the overlap. So what's that saying is that the more stretch you have of those heart muscles due to the filling of blood, they're going to be in more optimal length in the overlap of the thick and thin filaments to give you a stronger contraction. So the more blood that returns to the heart, and the more preload that you have, is going to have a greater stretch of the ventricles. That's going to put the overlap of the actin and myosin, those sarcomeres, give it a more optimum overlap. That's going to give you more force, which is going to be generated by the ventricles, and you're going to have more blood pumped out, or an increase in stroke volume. This is up to a point though, because as the graph is showing here, that yes, as you stretch those sarcomeres, your end diastolic volume is increasing, which is going to give you greater stretch, which is going to cause a greater increase in force of contraction up to a certain point. And then if you stretch them out too far, well, you're going to lose contractile strength. That's because those sarcomeres are going to be stretched so far out that the myosin heads aren't in contact the way they should be with the thin filaments. You only have a few versus a lot, and therefore you're not going to have a stronger contraction. Frank-Starling law of the heart says that you're going to stretch out the muscle and the muscle is going to contract stronger. To a point though. You can overstretch that cardiac muscle with too much blood filling into the heart, and you're not going to get a stronger contraction up to a point, which is shown here in this graph. So in the Frank-Starling law of the heart, what this is showing is that you have changes in contractile strength and stroke volume that are due to variations in the degree that the myocardium is stretched by the end diastolic volume. And this explanation right here, you can go through and read it. This is what we already talked about. This is what I just talked about, but certainly going through and read it will help you to cement it in. And if you have any questions at all on the Frank-Starling law of the heart, please let me know. So let's test our knowledge. As venous return increases, stroke volume is going to do what? Increase. As end diastolic volume decreases, stroke volume is going to decrease. If I have less blood in the heart, less blood is going to get pumped out of the heart. As heart rate increases, what's going to happen to your stroke volume? That's going to increase up to a certain point. But like I said, if your heart is beating way too fast, it doesn't have time to fill, and you're not going to get as much stroke volume out with a heart rate that's way too fast. So in the Frank-Starling law of the heart and total peripheral resistance. And what this is saying is that the Frank-Starling law of the heart explains how the heart can adjust to a rise in total peripheral resistance, or the resistance that that heart has to push against. A rise in peripheral resistance is going to cause a decrease in the stroke volume of the ventricle, just initially. So if you have a rise in total peripheral resistance, the ventricle goes to contract to move the blood out, but that contraction doesn't move all that blood that it would normally move out. So then when it relaxes, it has a little bit more blood in it than it would have normally had there been not as much total peripheral resistance. So in number 2, the more blood remains in the ventricle, and the end diastolic volume is greater for the next cycle. As a result, that ventricle is going to be stretched to a greater degree in the next cycle, and it contracts more strongly to eject more blood. This allows a healthy ventricle to sustain a normal cardiac output. So if your total peripheral resistance increases, the amount of blood that gets pumped out of the heart during the stroke volume is going to decrease initially, which is going to mean that you have more blood in the heart after it contracts. Then you have blood coming in to those ventricles as normal. That's going to cause the ventricles to stretch out a little bit more because it has blood from the preceding contraction that didn't get pumped out. That's going to cause more stretch, and due to the Frank-Starling law of the heart, you're going to get a stronger contraction. Total peripheral resistance, also called the afterload, this refers to the pressure against which the ventricle must pump the blood. That's what you have in your aorta here. It's the pressure that must be overcome in order to open those semilunar valves to eject the blood. So for this semilunar valve right here, which is called the aortic semilunar valve, for that to open, that ventricle has to generate enough force to push the blood against the resistance here that's in the aorta. That's going to have that blood move out. So the afterload for the left ventricle is the blood pressure in the aorta. If you have somebody who has high blood pressure, that means that that ventricle has to pump against a higher blood pressure to move the blood out. It has to work harder. The lower your blood pressure, the less the ventricle has to pump to move the blood out in that aorta. Now you also have pressure within the pulmonary artery as well, but generally when we're talking about cardiovascular disease, we're talking about blood pressure, high blood pressure, it's referring to the left side and what happens on the left side to get that blood out into the aorta. If aortic blood pressure is high, due to, say, hypertension, the left ventricle will have to expend a lot more energy to open the aortic semilunar valve and expels less blood. Now, if aortic blood pressure is low, the left ventricle will expend less energy opening the aortic valve and expel more blood. So stroke volume is going to be inversely proportional to peripheral resistance. Hence, the greater the peripheral resistance, the lower the stroke volume. Question: in a healthy heart, how is a rise in total peripheral resistance compensated for by the heart? Hint: Frank-Starling law of the heart. And basically, the Frank-Starling law of the heart is going to explain how a rise in total peripheral resistance causes a decrease in stroke volume of the ventricle, so that more blood is going to remain in the ventricle, which is going to cause an increase in end diastolic volume for the next cycle. And as a result, that ventricle is going to be stretched to a greater degree, and in the next cycle, it's going to contract more strongly to eject more blood. That's how the heart can be regulated intrinsically with increased total peripheral resistance. it's going to work harder. It's going to pump more blood. It's not due to hormones, not due to nerve innervation. This is intrinsic to the heart. This is within those heart muscle cells.